Welcome back to the deep dive. Today we are strapping in for what is really the ultimate race against the clock.
It really is.
When you think about the most time-sensitive crises in all of medicine, I mean, few things even come close to a stroke. We're doing a deep dive into acute ischemic stroke, or AIS. This condition it's just so serious. It's the second leading cause of death globally.
And what's maybe even more heartbreaking, the #1 cause of long-term disability right here in the United States.
Right.
And that reality is exactly what drives the protocols we're going to explore. We're using the Emergency Neurological Life Support Protocol for AIs as our map.
The ENLS protocol.
Exactly. This deep dive, it's really meant to be a shortcut to show you how clinicians can go from that very first assessment to a life-altering intervention.
And do it incredibly fast.
In less time than it takes to order a coffee. It's just stunning.
So our mission today is pretty straightforward. We want to unpack these really high-stakes decisions that define stroke care. We need to understand when and why they use these powerful clot-busting drugs, the thrombolytics.
Versus when they go in and physically remove the clot, the thrombectomy.
And all of it, I mean, absolutely all of it, hinges on this one critical and often very tricky piece of information: the last known well time.
It is the ultimate race, and the targets are ruthless. We are talking door-to-CT imaging in 20 minutes.
20 minutes.
And the single most critical primary target, door-to-needle time, that's the moment the drug hits the bloodstream, is 60 minutes.
But I hear they're trying to push that even faster.
Oh, absolutely. The secondary target, the one everyone is really aiming for, is 45 minutes or less. The speed required. It's not just impressive, it's what defines whether a patient walks out of the hospital or not.
Okay, so let's start right there. That crucial data point. Last known well, or LKW. Why is that specific moment, the moment of being well, so much more important than, say, the time the patient arrives at the hospital?
It's all about the risk-benefit calculation. When an ischemic stroke happens, you have this core of tissue that dies almost immediately.
Right, the ischemic core.
Exactly. But surrounding it is what we call the penumbra. That's the tissue that's sick, it's at risk, but it's still salvageable.
And that's what we're fighting for.
That's what we're fighting to save.
Yeah.
And its vulnerability is all about time. The effectiveness of those clot busters, it just drops off so rapidly. And on the flip side, the risk of causing a bleed in the brain, a hemorrhagic conversion, it rises dramatically.
That makes perfect sense. But what about the wake-up stroke? This must happen all the time. If I go to bed fine at 10 p.m. and wake up paralyzed at 7 a.m., what is my LKW?
And that's the toughest scenario. The protocol is very rigid here. The LKW is the time the patient was last confirmed to be normal.
So in my case, that would be 10 p.m.
10 p.m., the time you went to bed. Unless, and this is big, unless you woke up in the middle of the night, someone saw you, confirmed you were fine, and then you went back to sleep.
Yeah.
That unconfirmed gap in time, it's the biggest challenge. It can immediately disqualify a patient from certain therapies.
So the job of spotting these signs, it usually falls first to EMS, to the paramedics. They're using simple mnemonics, right? Like be fast.
Yes, BE fast is the standard. Balance, eyes, face drooping, arm weakness, speech difficulty, and then the crucial T's for time.
And you mentioned the speed. It's not just about clinical care. It's about the whole system moving at top speed.
They're system targets.
Yeah.
The clock starts the second the 911 call hits. Less than 90 seconds to dispatch the team.
Okay.
Less than 8 minutes for the ambulance to get there. And here's the really tough one. Less than 15 minutes total on the scene.
15 minutes on scene. That's barely enough time to even assess the patient.
It's a triage masterclass in minutes.
So in that tiny window, what are the absolute non-negotiable checks before they transport?
It's the basics, done perfectly. The CAB assessment, circulation, airway, breathing. Supplemental oxygen, but only if saturation is below 94%.
Okay.
And, crucially, check blood glucose right then and there. Plus, they have to perform a validated stroke severity scale, something like FAST-ED or RACE, to really quantify the deficit and help decide where to go.
Which leads to a fundamental question. What if EMS suspects a large vessel occlusion, an LVO, a big clot in a major artery, but they know the patient is outside that 4.5-hour window for the clot-busting drugs?
That's the critical system decision. If the patient screens positive for LVO, often using a tool like the VAN scale.
Vision, aphasia, neglect.
Right. Then direct transport to a comprehensive stroke center, one who can do a mechanical thrombectomy, is recommended. You actually bypass the closer primary stroke center.
So you trade a little bit of time on the road for getting to the definitive treatment faster?
Exactly. Because with LVOs, the only proven treatment is often to physically go in and pull that clot out.
Okay, so the patient hits the emergency department doors. That clock is still ticking. Imaging is immediate. Why do you have to start with a non-contrast CT, and why is the pressure so intense?
Priority number one is safety. Before we even think about giving a powerful clot buster, we have to rule out an intracranial hemorrhage, an ICH,
I'll bleed.
a bleed. If the patient is actively bleeding into their brain, giving a thrombolytic would be absolutely catastrophic. So the non-contrast CT rules that out
I see. And it has to be interpreted fast.
within 45 minutes of arrival. We're also looking for signs that the stroke is already too extensive. Say, if it involves more than a third of a hemisphere, because that tissue is likely already dead, and treating it carries a huge risk of causing a bleed.
Now, the sources mentioned something I found really surprising about lab work. In this high-speed scenario, you'd think they'd need a full coagulation panel, but the protocol lets them proceed with just one result.
That's right. The single essential lab test is a point-of-care blood glucose.
Just glucose. You don't wait for the clotting factors.
You don't wait. The reason is simple. Severe hypoglycemia can perfectly mimic stroke symptoms, but it's easily and instantly reversible with glucose.
Ah, so you rule out the mimic first.
You rule out the mimic.
Yeah.
You definitely order the other labs, INR, PTT, platelets, but waiting for those results, unless you have a very strong suspicion of a bleeding disorder, is considered an unacceptable delay. Logistics can't trump the time window.
Okay, so imaging's done, glucose is checked. The next step is quantifying the damage with the NIHSS, the National Institutes of Health Stroke Scale.
Right, the gold standard for scoring the deficit. It runs from 0, which is no deficit, up to 42, which is, a very severe deficit.
And it's not just a number, it's a language.
It's a language for the whole team, and it helps predict outcomes.
Yeah.
But what's really fascinating is the clinical nuance around that score. You might think a low score, say a 3 or a 4, means the patient is too well to treat.
But that's not always the case.
It's not, if the symptoms are fundamentally disabling to that patient.
So what's an example of a disabling symptom with a low score?
Absolutely. So imagine a patient whose score is low because their weakness is subtle, but they have complete severe aphasia. They can't communicate at all.
Or they can't see properly.
Exactly. An isolated visual field cut, a hemianopsia that compromises their ability to safely walk around or drive. These things are immensely disabling. The protocol says the clinician should ask the patient directly, do your symptoms stop you from living your life? If the answer is yes, they often warrant treatment.
We should also quickly mention the mimics, seizures, migraines.
We do, but the ENLS protocol is clear. Prioritize treating the potential stroke. Studies have shown that giving thrombolysis to someone who turns out to have a mimic, well, it carries a very minimal risk, much lower than the risk of not treating a true stroke patient. When in doubt, you treat.
All right, let's get into the first big intervention, intravenous thrombolysis. The window for that is up to 4.5 hours from the last known well time. The standard drug is alteplase, but you mentioned an alternative is gaining ground.
That alternative is Tenecteplase. Now, alteplase is still widely used. You dose it over 60 minutes with an initial bolus.
Yeah.
But Tenecteplase is recommended more and more because of its logistical advantages.
How so?
It's given as a single, quick bolus dose. That just dramatically simplifies the workflow. It reduces the chance of infusion errors, and it shaves precious minutes off that door-to-needle time. And it's been shown to have similar efficacy and safety.
Okay, and this is where it gets really interesting. This is a key takeaway for anyone listening. The blood pressure targets. They're not just stripped, they completely flip depending on the treatment.
This is the absolute high-stakes nuance. To even be eligible for thrombolysis, the patient's BP has to be aggressively lowered to below 185 over 110.
So you have to bring it down first.
We have to bring it down using short-acting IV agents like labetalol or nicardipine. If the pressure is too high, the risk of bleeding just skyrockets the second you give the drug.
Okay, so let me get this straight. You drop the pressure to get the green light, but then as soon as the infusion starts, you change the goalposts.
You do. Once the drug is in, we shift to maintenance. The goal is now to keep the BP below 180 over 105 for a full 24 hours.
A slight lower target.
A slightly lower target, just to mitigate that peak bleeding risk in the hours right after treatment.
But that's only for patients getting the drug. What if they're outside the window, or they can't get any kind of clot removal?
Then we do the opposite. We intentionally allow what's called permissive hypertension. We actually let the pressure run high, up to 220 over 120.
Why would you do that?
It's protective. In the presence of a blockage, that higher pressure helps force blood through smaller collateral vessels to perfuse the brain tissue around the clot. We only start lowering it if it goes above that 220/120 ceiling.
Okay, so moving past that 4.5-hour chemical window, we get to mechanical thrombectomy for the big clots, the LVOs. What defines that early window for physically pulling the clot out?
The early window is generally up to 6 hours from last known well. The criteria are usually a confirmed LVO, an NIHSS score of 6 or more, and a good aspect score.
Explain aspects for us.
The aspect score is a 10-point system from the initial CT scan. It basically quantifies how much brain tissue has already been irreversibly damaged. A score of 6 or higher usually means there's enough salvageable tissue left to make the procedure worthwhile.
But then came the late window pushing treatment out to a full 24 hours. That just redefined everything. How can you justify pulling a clot that long after symptoms started?
This is where advanced imaging becomes mandatory. We use CT or Reperfusion studies to look for what's called a mismatch profile.
A mismatch between what and what?
We map the core of the stroke, the tissue that's already dead against that surrounding penumbra, the tissue that's still at risk. The revolutionary Dawn and Diffuse 3 trials prove that if you have a small core and a large penumbra,
You can still save that tissue.
you can still go in, pull the clot, and save that tissue, even 24 hours later. The decision becomes less about the clock on the wall and more about the patient's individual physiology.
So assuming the acute intervention is done, or it was ruled out, and the patient is admitted, the focus shifts. What are the key general orders in the hospital?
It's all about neuroprotection and stability. We maintain euvolemia, which is normal fluid status, with isotonic saline. Tight glucose control is critical. We aim for a range of 140 to 180.
Because big swings are bad for the brain.
Both hypo and hyperglycemia worsen outcomes. And crucially, we prevent fever. Any temperature over 37.5 Celsius has to be treated aggressively because that heat exacerbates the injury.
And before they can have anything to eat or drink, there's one non-negotiable assessment.
The bedside swallow assessment. Stroke so often causes dysphagia difficulty swallowing. If a patient aspirates, they can get pneumonia, which is a huge driver of poor outcomes. So no oral intake until they pass that swallow screen.
And given the huge bleeding risk from the thrombolytics, what are the restrictions on other procedures for that first day?
For 24 hours after thrombolysis, we have very strict restrictions. We avoid placing any indwelling catheters, no urinary, no nasogastric, no arterial lines, unless it's absolutely essential for life support.
And no blood thinners.
Critically, no anticoagulant or antiplatelet therapy for that full 24-hour period.
What happens if the worst-case scenario occurs? The patient rapidly declines, and you suspect a post-thrombolytic bleed in the brain.
It's an all-hands-on-deck emergency. First, stop the infusion if it's still running. Get a stat head CT to confirm the bleed. Then, reversal agents are mobilized immediately.
Like what?
The common protocol is giving cryoprecipitate, trying to get their fibrinogen level up, often combined with an antifibrinolytic like tranexamic acid to stabilize the clot. And you notify neurosurgery immediately.
Okay, let's pivot to the TIA, the transient ischemic attack, the so-called mini-stroke. The symptoms resolve, so why is it still considered such an emergency?
Because a TIA is a massive warning sign. It means the patient's circulation is compromised and they are at an extremely high risk of having a major debilitating stroke very, very soon. We treat it as an emergency to prevent that bigger event.
And you quantify that risk with the ABCD2 score.
Right. It's based on age, blood pressure, clinical features, duration, and diabetes.
And how does that score guide what you do?
It creates a risk hierarchy. A low score, say 0 to 3, means the patient can probably have an expedited outpatient workup. But we start them immediately on an antithrombotic, usually aspirin, and a high-intensity statin.
But a high-risk score 4 to 7, that's a different story.
That's an admission to the hospital standard practice. And based on trials like POINT and CHANCE, we now use a more aggressive approach. Dual antiplatelet therapy, DAPT.
So 2 drugs instead of 1.
Exactly. Aspirin combined with clopidogrel or ticagrelor for a specific short period, usually 21 to 90 days, to get them through that highest risk period right after the TIA.
This deep dive really shows that emergency stroke care it's a masterpiece of structured systems. It's all designed to eliminate ambiguity when every second counts.
It really is. It's years of clinical trials condensed into these non-negotiable checklists that let an entire system make life-altering decisions incredibly fast.
And that speed is vital, but it must come with immense pressure.
It does. And if we connect this to the bigger picture, it highlights some really complex realities in medicine today. For instance, you look at the legal record. Far more lawsuits are filed against providers for the failure to offer thrombolytics than for complications that arise from giving them.
Wow, so there's enormous pressure to treat.
Enormous pressure.
See.
It compels clinicians to act aggressively and quickly, even if family consent or a clear decision maker isn't immediately available. The protocol prioritizes the patient's brain over bureaucratic delay.
That tension, that ethical tightrope, it really defines those first 60 minutes. So given all these challenges with LVOs and late windows, let me leave you with a final provocative thought.
Okay.
We know that for LVOs, mechanical retrieval thrombectomy is often the best treatment. The current drip and ship model is common, right? Give the clot buster at a local hospital the drip, then transfer them for the procedure, the ship. But given how good mechanical retrieval is for those big clots, is prioritizing that initial drip always the best strategy? Or are we just delaying the definitive treatment? Should we instead focus all our resources on just accelerating the transport straight to the thrombectomy suite, minimizing any delay at all to mechanical removal? That balance is still being fiercely debated in stroke systems around the world.